Hey, I'm Rob. I'm a neurology resident. Let's speed run some high-yield neuroanatomy. It's kind of dry. Hang in there. We'll get through it. It's clinically relevant. We're going to start off with some histology. We're not going to look at any actual slides. We're just going to talk about the cells. You kind of need to know some of these cells. You at least need to know these cells and what they do. Glial cells are the overarching family. They are the support crew of the nervous system. They're split into two groups, the macroglia, which includes oligodendrocytes, astrocytes, Schwann cells, and ependymal cells. These come from the neuroectoderm, except for Schwann cells, which come from the neuro crest. That's a key differential. Microglia are different. They are the resident immune cells of the CNS. They are responsible for the inflammatory response, and they come from the mesoderm. This is the highest yield chunk of the whole lecture. Astrocytes are the multitasker. They maintain the blood-brain barrier through their foot processes. They metabolize and recycle neurotransmitters. They buffer potassium, and they proliferate after injury, reactive gliosis. Clinically, they're your GFAP positive cell, and their most feared tumor is the glioblastoma multiforme. Ependymal cells line the ventricles. They're ciliated and they help move and produce CSF. Their tumor is the ependymoma. Oligodendrocytes myelinate CNS neurons. One oligo can myelinate multiple neurons at once. This is a key differentiator from Schwann cells. And they make up white matter. Clinically, think demyelination, MS, PML, plus their tumor, oligodendroglioma, and the classic fried egg appearance on histology. Next, Schwann cells, they myelinate the PNS. This is a key differentiator, but strictly one-to-one, again, key differentiator. One Schwann cell, one axon. Clinically, GBS/AIDP. Their tumor is a vestibular schwannoma, schwannomatosis. Next, microglia, the phagocytes of the CNS and HIV infection. They fuse into multinucleated giant cells. This is a key thing to know for STEP. And after a brain infarct, they're the ones clearing dead tissue through liquefactive necrosis. More on that later. Overall, know the cell, know what its function is, and then know what the clinical correlate associated with it is. Next, I want to clear up the difference between liquefactive necrosis and gliosis. Both represent responsive to injury. However, they mean opposite things, and clinically, a lot of times they're used interchangeably, which doesn't really make sense given that they mean opposite things. Liquefactive necrosis is the characteristic form of necrosis in the CNS, occurring because the brain tissue has relatively low protein content and high lipid/water content, making it prone to enzymatic degradation rather than coagulation necrosis as seen in other organs. Gliosis is a gradative reparative response of astrocytes and microglia to CNS injury characterized by cellular hypertrophy and proliferation, the exact opposite of liquefactive necrosis. The last key high-yield point, and it's kind of an easy one to fall for. Don't confuse immunohistology stains with genetic or oncogenetic markers. GFAP and S100 are protein stains, which means certain cells express these proteins, and when we stain for this, we can identify the cell lineage. GSTAP stain glioblastomas and pilocytic astrocytomas. S100 stain schwannomas and melanomas. That's it. Thanks for sticking with me. You're a beast. Don't hesitate to give me a follow if you actually want to learn how to understand your brain.